Doamnelor și domnilor, este o plăcere să vă doresc bun venit din nou la sesiunea de după amiază din a doua zi a școlii de toamnă de reumatologie, care se desfășoară anul acesta la Sibiu și, desigur, împreună cu toți ceilalți colegi conectați online. Este de asemenea o plăcere să vă pot introduce prezența profesorului Peter Taylor, care este titularul Catedrei de Reumatologie de la Universitatea din Oxford. Este un reputat specialist, în special în domeniul artritei reumatoide, iar astăzi va vorbi despre siguranța unei clase terapeutice nou introduse în reumatologie, respectiv a inhibitorilor de ionoschinază. Vă rog să profitați de această ocazie pentru a adresa întrebări și a face comentarii la sfârșitul acestei prezentări. Dear Peter, I was just introducing you. It's a pleasure and a privilege for me to welcome you. It's an autumn school of rheumatology which is dedicated to young rheumatologists. In fact, we have 20 young or very young ladies rheumatologists in training here in Sibiu, and it would be a pleasure to have you also in person here in Sibiu. Unfortunately, due to travel restrictions, it's obviously not possible right now. Hopefully, we'll manage to do it in the next future. So the floor is yours.
Well, thank you, Katalin, for such a kind introduction, and it's always a pleasure and an honour to work with you, and my warm wishes from England to all the trainees there. You couldn't be working with a better tutor, and I know there's very fine rheumatology indeed in your country. You'll also be warmly welcome to visit us in Oxford one of these days when travel is possible. Well, my task in the next 45 minutes or so is to talk about the safety of JAK inhibitors, and of course there's been a lot of expanding knowledge in a very short time, so we'll explore all this together. Here are my disclosures. And now let's start off by thinking about safety considerations for all our patients with rheumatoid arthritis, irrespective of any therapeutic intervention. You'll all be aware that rheumatoid arthritis is associated with various risks. Of course, there are physical restrictions with reduced mobility, and this may in itself lead to an increased risk of infection. And the immune dysfunction involved in rheumatoid arthritis may also alter the infectious risk, and I'm going to show you some data for this shortly. And rheumatoid, if it's untreated and becomes established, may be associated with many comorbidities, and you'll be familiar with some of these: cardiovascular, interstitial lung disease, and others. But from a perspective of daily practice, some of the things we are concerned about when treating our patients are infections, tuberculosis, herpes zoster, and there are other bacterial and viral infections, of course. We need to think about skin cancers and lymphoma. And we also need to think about cardiovascular risk and the dyslipidemia that may be associated with rheumatoid arthritis and treatment, and the fact that cardiovascular events are more common in these patients. So there are a lot of things to be thinking about when we treat a patient with rheumatoid arthritis. Now, if you look at these graphs, on the left-hand side we're looking at severe infections that require hospitalization, and on the right-hand side we're looking at herpes zoster. And there's a comparison of rheumatoid patients in the blue, and in the darker color, or dark blue, there's a healthy age and gender match control. And you can see at a glance that our rheumatoid patients are more susceptible to a whole range of serious infections, from pneumonia through to osteomyelitis, and they are also more susceptible to herpes zoster, and this tends to increase with age. So the older the patients are, the higher the risk of infection tends to be. So often when we're training in rheumatology, we think about the infectious risk of treatments, but you mustn't forget that undertreated or untreated rheumatoid is associated with infection. So the trick is to get the balance just right, not to overcook our patients with treatment, and equally not to leave them untreated. So when we think about evidence-based, we like to think that we live in a world of evidence-based, and that's partly true. But there are many different kinds of evidence, and one of the most stringent kinds of evidence is from randomized controlled trials. But the disadvantage there is that the patients in trials may not be representative of the patients you see in the clinic. And then there's registry data, which all our countries contribute to, but this is less rich in its detail. And then there's real-world reporting, which gives you very large epidemiological studies, but the detail may be really very poor indeed. So these are the different lines of evidence, and we're going to have a look at this in the context of the JAK inhibitors. So we'll start off with tofacitinib, which is said to be a JAK1/3 inhibitor, but in fact it has a pan-JAK effect. And what is the evidence from clinical trials? Well, tofacitinib was the first JAK inhibitor to be approved, and therefore there's a huge amount of evidence. And what you're looking at in this table is two different doses of tofacitinib. On the left-hand side, 5 milligrams twice daily, which is the approved dose in rheumatoid arthritis. And in the middle, another dose that was tested was 10 milligrams twice daily. And I just want to focus on a few issues here. So if you look at the highlighted row here, you can see that roughly 1 in 4 patients need to discontinue tofacitinib because of some sort of adverse event. Of course, other people will discontinue because of lack of efficacy. But it is important to bear in mind that whilst this is a good drug, 1 in 4 patients will have to stop because of some side effect. Now, the data from clinical trials now extends to 9.5 years, and this is the most recent publication. So that's a very long exposure to tofacitinib at the different doses. And in the left-hand column, you're looking at the approved dose, 5 milligrams twice daily. And really, if we look across these columns, the one thing that particularly stands out here is herpes zoster. So what we've learnt with respect to JAK inhibitors is that herpes zoster is more common with JAK inhibitors than it is in the untreated population, and it's more common than it is with biologic drugs, although they can also increase the risk. If you look at the other adverse events in this table, it's not dissimilar to what you would expect with a biologic targeted therapy. So what we can now look at, what I showed you just now, was an uncontrolled period. So in other words, it's just patients who've been exposed to tofacitinib for 9.5 years. But what we can also do is look at the placebo-controlled period of the study, which is usually only for the first 6 months, because it would be unethical to give placebo for longer time periods. And if you focus on the left-hand side here, you can see that in the placebo-treated arm, the herpes zoster rate was 2, and in the tofacitinib 5 milligram twice daily arm, it was double that. So here we can contextualize with placebo. So herpes zoster is an issue. Serious infections were also more frequent with tofacitinib than placebo, but nonetheless within a range that you'd expect for a biologic, and probably with an acceptable risk-benefit from a patient perspective. There were very few cases of tuberculosis in the clinical trials, and that of course contrasts with biologic anti-TNF, which carries an increased risk of reactivation of TB. And if we now look at events of special interest and just focus on the TB issue and go beyond the placebo-controlled stage up for the next 8.5 to 9.5 years, you can see that there were some cases of TB reported. I think this is particularly important in your country, where I think the background rate of tuberculosis is higher than it is in my country, in the United Kingdom. So we do need to be aware of this. But the important point here is that tuberculosis is an uncommon event with tofacitinib, where of course with anti-TNFs you might expect higher rates. Now, what about cancers? One of the other things we worry about as physicians is non-melanoma skin cancers. So these are usually non-serious skin cancers, but we do need to spot them and ensure that patients are treated. And what you can see in this graph, which expresses the rate per 100 patient years of exposure, and this is a cumulative exposure, that if you go over time out to over many years, that in fact there is no increase in rate of non-melanoma skin cancer over time. So this is actually very reassuring. It is something that occurs, but only at around the background rate expected, and it doesn't seem to get worse with increasing exposure to drug. Now, if we look at malignancies excluding non-squamous cell carcinoma, then actually you can see that, again, the incidence doesn't appear to increase over time up to many years of exposure. And a good figure to bear in mind, if you're not familiar with this, the background rate of malignancies excluding non-melanoma squamous cell carcinoma would be approximately 1 per 100 patient years. So in fact we're seeing really the expected background rate and not an increase over background with tofacitinib. Now, another one of the problems that we worry about is so-called MACE events, and this is an acronym. It stands for Major Adjudicated Cardiovascular Events. So in other words, these are heart attacks or myocardial infarctions that have been confirmed by an expert. And again, you'd expect the background rate to be around about 0.8, 0.9, something like that in rheumatoid arthritis. But you can see here the rate per 100 patient years of exposure is in fact lower than expected, and it doesn't increase over time. So again, this is very reassuring. And one of the things I would recommend to you as trainees, I'm sure you're all very good at communicating with your patients, but it's so important what we say to patients, and we need to encourage our patients, if they do start on a drug like this or any of the JAK inhibitors, we can look at the patient and tell them with confidence that we don't expect this to increase any heart risk over the years, and in fact it's possible that in fact any heart risk may even decline because you're treating inflammation. So what we've looked at so far is safety data with respect to the clinical trials, and this drug tofacitinib has the longest history of use in the clinic in various parts of the world. It was first approved in America. But what about other kinds of evidence, and what about the real world evidence? And this is important too, because many of the patients in clinical trials are not the same as the patients that you and I see in clinic every day. So we can address this issue by looking at registry data, and this is registry data from the United States, where they've had the longest access to tofacitinib, and this is the so-called Corona registry. And here there's a comparison of these various adverse events between tofacitinib and biologic agents. The biologic agents are favoured, in other words have a lower rate if you're on the right hand side of the vertical line. If you're on the left-hand side of the vertical line, it favours tofacitinib. So what we're seeing here is the only adverse event of these three where it's statistically significant is herpes zoster. I don't know if you can see my mouse pointing, but here we are. In two different forms of analysis, you can see that herpes zoster is actually the adverse event that is increased with tofacitinib and lower with biologics. But for myocardial events and for serious infectious events, it's very similar in real-world practice. And again, that's something to bear in mind, that we can tell our patients when they're asking us about the side effects of drugs. And they may be choosing between an injectable drug or an oral drug. And you can tell them that with respect to infectious complications, then actually the risk is very similar with either a biologic or with a JAK inhibitor. It's different though for zoster. Now, another way we can do this is to contextualize the infectious risk of conventional DMARDs and biologic DMARDs, and we can do that by stratifying for age. Because one of the controversies has been in trials that if you're older, and that means over 65, not young like yourselves who are all well under 65, then actually your risk of infection may be greater with JAK inhibitors. So what is the evidence? Well, just to take you very briefly through this, the evidence comes from real-world observational studies, and this is a database from the United States where patients were recruited and they had questionnaires to follow up their progress either when they'd received a biologic drug, it could be an anti-TNF or another biologic, or a conventional synthetic DMARD over a period of a number of years. And then the safety outcomes were documented according to the patient report. So this is real-world data. It's less detailed and less well-controlled than clinical trial data, but it's more representative of the patients we see in the clinic. And here are the findings that if you look at the background information, this is simply to point out that in these three groups of patients, the ones receiving conventional synthetic DMARDs on the left, in the middle, the anti-TNF treated patients, and on the right-hand side, the patients treated with other biologics than anti-TNFs, that they're fairly well balanced. So these very large groups of patients are very similar. Their average age is around about 60. They're predominantly female. They've had disease for a long time, 15 years or so, and over half of them have used glucocorticoids. So what then is the data? Well, this is quite an important graph, I think, because what you see with this huge population in the study is that the older you are, the greater your risk of infection, and that's irrespective of which drug you've had, whether it's conventional synthetic DMARDs like methotrexate or any biologic DMARD. So in other words, increasing age increases your risk of infection, and obviously we need to be mindful of that when we're prescribing our drugs and to mitigate against the risk where possible. So let's look in a little bit more detail at this business of a difference in infectious rate depending on whether you're over 65 or under 65, and ask what's the evidence from clinical trials where we've got more granular detailed data. Well, this was a post hoc analysis looking at the clinical trial program in a number of trials, phase 3, and also the open label extensions, and this was published fairly recently. And what they did in this study was they compared the 2 doses of tofacitinib that were tested, the 5 twice daily and the 10, in these different patient populations. And remember again that it's only the 5 milligram twice daily that's approved now for treatment. And the outcomes that were studied were efficacy outcomes, in other words, how well does the drug work in these clinical trials, but to compare that with the safety, so we've got some idea of the benefit versus the risk. So let's have a look at the results. So on the left-hand side, you're looking at serious adverse events, and on the right-hand side, we're looking very specifically at serious infectious events. So serious adverse events are unfortunately quite common in clinical trials, but what you can see at a glance is that whether you're looking at patients who are under the age of 65 or over the age of 65, that actually it's always the older patients that have the higher rate of adverse events. And if we look at serious infections on the right-hand side of this slide, you can see that it's the older patients who have the highest risk. So in fact, it goes up to about 8 per 100 patient years, whereas in the younger patients who are between 50 and 60, that sort of age, it's round about 3 per 100 patient years. So on average with a biologic you'd expect about 3 to 4 per 100 patient years, but we need to be careful that in the more elderly patients there is a higher risk. So an important question for our elderly patients is, do they think the benefit of these drugs is worth the risk? And for many of them the quality of life will be worth taking that risk, which is still relatively small overall. And of course we can reduce the risk by educating the patients about preventing infection. So what is the very latest data from clinical trials on this issue, looking at over 65 and under 65? Well, the very latest data came from another post hoc analysis which was presented just this year at EULAR, so just a few months ago. And this is looking at patients from a number of trials and looking at serious infectious events. and then dividing them as occurring between the older and the younger patients. And not only were we able to look at the 2 doses of tofacitinib, but also at the comparator of adalimumab or placebo, because in the oral strategy study, adalimumab was used as a comparator. And here are the data. So if you look over on the left, you can see that the rate of infectious events, serious infectious events, is somewhere between 3 to 3.5. It's a little bit higher numerically than it is with adalimumab, and adalimumab is a little bit higher than placebo. That's overall. But if we now look at the difference between the younger patients in the middle, meaning under 65, and the older patients on the right, it's very clear that the higher dose of tofacitinib, which is no longer approved, but which was tested in clinical trials, is associated with a much higher risk numerically, although the confidence intervals are so high that it still doesn't meet statistical significance in this analysis. So the point is there is a trend towards a higher risk of infection with a higher dose and with a higher age. You'll note that even in the 5 mg twice daily, the rate of infection is almost double that which it is in the younger age group. So this is something for us to bear in mind when we treat our patients. Depending on their age, their risk may differ. And if you look at the hazard ratios across these studies, stratified by age, in other words, the younger or the older patient group, in the top part of this forest plot, you can see the younger age group, where actually there isn't much difference in risk between tofacitinib and adalimumab. At 5 mg twice daily, there's a trend for lower risk with adalimumab. But in the older patients, there's still a trend, but it becomes close to significance for the higher dose of tofacitinib compared to adalimumab. So, in other words, you would not necessarily want to choose 10 mg twice daily if you had the option compared to adalimumab in a more elderly patient. But in my country, we don't have that option of the higher dose. I don't think you do either. So there are differences that become more apparent the older you get. Now, it's all very well looking at this clinical trial data and real-world data, but we need to get some idea how different drugs compare. And one of the ways you can do this is actually by looking at insurance data, and this is from the United States, which has a very different healthcare system from us in Europe. And in the United States, the insurers keep detailed records of not only the treatments that patients have, but also the side effects that may occur. And this is data from 3 different databases looking at different doses of tofacitinib and comparing them with various other biologics. And here is the data. And in fact, if you focus on the right-hand side, you can see the hazard ratios. So in fact, overall, etanercept turns out to have one of the lowest risks and a lower risk than tofacitinib. And in fact, infliximab has a trend to a higher risk than tofacitinib. But otherwise, the different biologics, the other anti-TNFs and co-stimulation blockers and anti-IL-6, they're very, very similar in their serious infectious risk. And again, this is something important to be able to tell our patients. But if we look at the difference between the younger patients and the older patients, on the left-hand side we're looking at the younger patients, and there the highest risk is in fact with infliximab and tocilizumab in the young patients. But ironically, in the older patients, we see slightly different, that we see that the lower risk is with etanercept and tocilizumab. So I think etanercept comes out very well out of this sort of analysis, and of course the numbers get a little bit lower with tocilizumab, which may explain the variability in data. But even so, you get an idea that for most of the biologics, the infectious complications have a very similar rate to those of tofacitinib. So that's tofacitinib. Now let's look at baricitinib. What's the evidence from clinical trials? Well, baricitinib, there's been a huge trial program again, and there's a placebo-controlled period over the first 6 months, and then you can pull the 2 and the 4 milligram once daily doses to look at other data, and then put everything together and look at these different data sets. And if we do that, you can see that there's a huge exposure. This data has been presented just last year. Over 3,500 patients receiving baricitinib for over 10,000 patient years of exposure. And that's between 3 and 7 years. And if we look by this analysis set, I'm just going to highlight for you that for serious adverse events, for placebo, here it is at 12. And if you look across the board, you can see it's very similar for baricitinib at 2 and 4 milligrams. And it's very similar, in fact, right across the board in all these different populations. If we now look at serious infections, again, the rate of serious infections is very similar in the trials for baricitinib versus placebo. And looking at the other adverse events, again, nothing really stands out as being very different. So this looks very encouraging. If we look at the data in a different way, this is 100 patient years of exposure. You can see that the expected rate of infections is about 4 per 100 patient years, very similar to what we saw with tofacitinib. It was similar on placebo, so in other words, undertreated rheumatoid carries an infectious risk as well. And if we look at cumulative exposure to baricitinib, it doesn't increase over time. So again, with the JAK inhibitors in general, we've seen that the longer you have them, it doesn't imply that you're more and more likely to get an infectious complication, which is good news. Looking at herpes zoster, however, there is a clear difference, and here it is again, that for placebo, the rate per 100 patient years is just over 1, but for baricitinib 4 milligrams, it's 4 per 100 patient years. So there is an increase, just as we saw with tofacitinib. But it doesn't change over time with cumulative exposure. So although there is this clear relationship between all JAK inhibitors and herpes zoster, it doesn't seem to be due to cumulative exposure. It's just a risk at any time point. But another very important thing for us to bear in mind is that the risk varies depending on your ethnic background. Now, I don't know whether you see many Oriental patients in Romania. I have a few in my practice in the UK. We're a very multicultural country. And if you're Japanese or Chinese, then your risk is higher than if you're European. So for us in Europe, meaning most endogenous Romanians, as it were, and I know in Romania you have many different cultural backgrounds as well. But for us, if you're white Caucasian, then your risk is about half that for the Asian patients. So bear that in mind if you have any Asian patients. Now, with respect to myocardial risk, with baricitinib, again, very similar to tofacitinib, the risk is 0.5 per 100 patient years of exposure, which, if anything, is less than the expected background rate, and it doesn't increase with increasing exposure to drug. So this is very pleasing and very reassuring, and again, something we can communicate to our patients. Similarly, for malignancy, you can see the rate of malignancy in all these data sets is very similar between baricitinib and placebo. The malignancy rate, this excludes non-melanoma squamous cell carcinoma, doesn't increase over time. Now, looking now at skin cancers, so this is non-melanoma skin cancer. Again, the rate here is very similar to the expected background rate. And again, if you've been on this drug for several years, it doesn't seem to increase your risk over being on the drug just for a short exposure. So it is something to look out for. We probably should check our patient's skin from time to time and just ask them about any skin lesions, but the risk is small. But again, what we've looked at so far is clinical trial data. In order to understand this and to advise our patients, where possible, it's nice to contextualize it. versus the other drugs that we might use, meaning other biologic drugs or conventional synthetic DMARDs. And here is the data. So looking at herpes zoster, you can see that the baricitinib in the red gives you a very similar likelihood of zoster to this is looking at compared to other biologics here, so tocilizumab, and here we have tofacitinib. And if you look at serious infections, again, the rate for baricitinib is very similar, both at the 2 and the 4 milligram dose compared to other drugs. In fact, tocilizumab seems to be slightly higher in terms of infectious risk. Looking at myocardial events, again, it's nice and low, and if anything, favourable compared to some other biologic drugs. And looking at malignancy, you see the same story. So we can reassure our patients where they have a choice of drug as to what the relative risk might be in terms of other comparable treatments that they might want to have. So that's baricitinib and tofacitinib. Now, baricitinib is a JAK1/2 inhibitor, but the other most recently approved JAK inhibitor is opportunistic, and this is said to be more JAK1 selective, although it does have some influence on JAK2 and JAK3 as well. And so now let's look at the opportunistic clinical trial together and see what you think. Now, this is the phase 3 program, and because it's a very big phase 3 program, the nice thing is that there are populations of safety that are methotrexate refractory, both in monotherapy and combination. There are populations who are conventional synthetic DMARD refractory, and populations who are biologic DMARD refractory. And this means we can look at the issue of safety across all these different populations. But essentially, to make things easy for us, I'm going to summarize things today. So if we look at an integrated safety analysis right across these populations, let's highlight some of the issues. So in the reddish color here, you have adalimumab. In the middle, you have methotrexate as a comparator, and on the left, you've got placebo as a comparator, and over on the right, you've got the approved dose of opportunistic, which is 15 milligrams once daily. And if we look at this, let's look at serious adverse events. You can see that adalimumab and opportunistic in these trials had a higher rate of serious adverse events than either methotrexate or placebo. But it's not that much higher, but there is a numerical difference. And then if we look again at zoster, once again this zoster signal comes up. So your likelihood of zoster per 100 patient years is around about 3.5 to 4 compared to 1 with placebo. So very, very similar data to what we saw with baricitinib and tofacitinib. And then if you look at opportunistic infections or other events at the bottom of this chart, they're really rather uncommon. And we'll go into some of these in more detail. So one of the ways that you can look at benefit versus risk is that on the top of this slide, we're looking at the various outcome measures from ACR 22 to 50, and then we're looking at low disease activity and remission. And if we look at these outcome measures, you can see that in fact opportunistic does very well, and it gives better clinical efficacy than adalimumab. We know that from the Select Compare study. But we can also look at the Select Compare study data for safety, and you can see that with respect to infections, malignancy, cardiovascular events and thrombotic events, that it's the same, but there's a trend towards an increased number of zoster events with the JAK inhibitor, so as we've come to expect. But you'll note that even there, the confidence intervals cross the zero boundary. Looking now at serious infections and opportunistic infections, and again comparing the different comparators, opportunistic at the bottom at 15 milligrams, adalimumab in the middle, and methotrexate at the top, you can see how similar adalimumab and opportunistic are with respect to infectious events, and similarly for opportunistic infection. So that doesn't mean to say that opportunistic doesn't have an association with opportunistic infection. It just means there's a small increased risk for both these targeted therapies. And it's very similar for each targeted therapy. The difference emerges, as we saw earlier, for herpes zoster. So looking across the phase 3 program, there is this numerical trend to an increased risk of zoster with upadacitinib, but even then you'll see that the confidence intervals are very close to those for adalimumab. But in this particular phase 3 program, there was not much difference between adalimumab and methotrexate. So zoster is an issue with JAK inhibitors, but most of the zoster cases are non-serious and most involve a single dermatome. And I think in the future, as vaccines become cheaper, we'll be vaccinating our patients. But in the meanwhile, if you're not able to vaccinate everybody, probably we only need to be more cautious in the elderly and more at-risk patients. With respect to malignancy, here you can see the comparative data, upadacitinib at the bottom, adalimumab and methotrexate at the top. And again, really there's not much difference between these drugs. There's a little bit of statistical noise with each of these, and so overall getting a very similar malignancy rate with all of these drugs. But this is the clinical trials, which is why it's going to be so important for all of us to keep good registry data to see what happens over the long term in real life. Now, another way of looking at these type of data when we're talking to patients is the patients want to know what are the common side effects. Well, the common side effects, meaning up to 1 in 10 people or more, would be upper respiratory tract infections, but non-serious infections which resolve, so the common cold and things like that. Common problems, meaning between 1 in 10 patients to 1 in 100 patients, include neutropenia, raised cholesterol, cough, nausea and pyrexia, and abnormal blood test results. And uncommon, meaning between 1 in 100 to 1 in 1,000 patients, you might expect to see herpes zoster or herpes simplex, which we haven't talked about so far, various more serious pneumonias and so on, and also hypertriglyceridemia. So this, again, just gives us some sort of context and helps in the communication we as rheumatologists have with our patients. Now, one of the most controversial issues has been venous thrombotic events. So what really is the evidence? Well, the background to this is complex because when you look at patients who don't have rheumatoid arthritis, of course some of them get venous thrombotic events. It's about 2.5 per 1,000 patient years of exposure for non-rheumatoid patients. And for rheumatoid patients, it goes up by about 2.5 times to 6 per 1,000 patient years of exposure. So in other words, rheumatoid patients are at higher risk of venous thrombotic events than non-rheumatoid patients. And if we look at the epidemiological studies, and here are all the epidemiological studies in rheumatoid, and you look at the average rate, in fact it turns out to be exactly the rates that are reported in the JAK Inhib studies. So for VTE, the average is around about 0.6 per 100 patient years. For PE, it's around about 0.2. For DVT, it's about 0.4. And if we actually look at the data, with baricitinib, the controversy arose because there was an imbalance in the placebo-controlled trial between the 4 milligram arm and the placebo period. But when these placebo patients were crossed to active drug, there didn't seem to be a signal for VTE, so it was difficult to know whether it was chance or actually causally related. And here's the issue, that when the placebo were crossed to baricitinib, the same high signal didn't occur. And when adalimumab patients were crossed to baricitinib, again, there was no signal for VTE. So this has been a controversial issue. So with the baricitinib clinical trial data, looking right across the latest data going up to 7.5 to 8.5 years, you can see that there's no increase in this rate of VTE over time. It's still 0.5 overall, which is exactly the background rate you'd expect. Now, if we look at tofacitinib, and this is looking at tofacitinib versus placebo on the left-hand side, and then versus adalimumab for DVT and for PE on the right-hand side. Again, there's no very obvious effect of tofacitinib for VTE events. But that's in this particular study. If you look at the Corona database in the United States, again, there doesn't seem to be any signal for tofacitinib compared to biologics. There's simply no difference. But in a clinical trial that was mandated by the FDA, there was a difference. So here's another study based on insurers where they compare biologics, conventional synthetic DMARDs, and targeted synthetic DMARDs, so in other words, any JAK inhib, and you'll find that, again, there's no difference between the JAK inhibs and the other treatments that we could use in these insurance databases. So it has been very controversial indeed. Looking at the upadacitinib data, here it is. So if you look at cardiovascular events on the left and venous thrombotic events on the right, there really doesn't appear to be an imbalance between upadacitinib and adalimumab or methotrexate. In other words, events were seen in all three treatment arms, as you would expect. The controversy about all this was in a study mandated by the FDA, where in a comparison with anti-TNF, tofacitinib was found at the higher dose to have about a 5-fold increase in VTE. So it may be that there is a rare relationship between some JAK inhibits and VTE, but probably only at higher doses. With respect to blood parameters, there are some differences in agents, so this has been nicely summarized in a review, and so I'm just going to highlight some issues for you here. So if you look at transaminases, they may rise, liver function abnormalities and cholesterol may rise with tofacitinib and baricitinib, and also with upadacitinib over there on the right. So all these three approved drugs have in common these changes on liver enzymes and cholesterol. But there are also some differences. So rarely in a small number of patients, baricitinib and upadacitinib have a decrease in hemoglobin. On average it doesn't change, but some patients go down, whereas tofacitinib, that's not so obviously seen. Hemoglobin tends to rise, and this probably reflects the JAK2 inhibition for baricitinib and upadacitinib. And if you look at the lymphocytes, again, it's a mixed bag. So in other words, we have a responsibility to monitor these patients just as we would our methotrexate patients. And what we need to look at is the neutrophil counts, lymphocyte counts, hemoglobin, transaminases and lipids. And what I do in my practice is if a patient starts on a JAK inhib, I would monitor them in exactly the same way as I would a patient on methotrexate. And for lipids, you check the lipids after 12 weeks of starting treatment and then treat them with a statin if the lipids go up. So finally, let's look at some practical tips. We've started out by saying that serious infectious events are a problem for rheumatoid in general, and therefore we really need to think about the likelihood of benefit versus the likelihood of risk. To monitor our patients carefully, educate them as to what to do if they get an infection, say a sore throat, a fever, runny nose, when should they stop their drug, etc. And think about maybe reducing the dose of JAK inhib where possible in more elderly patients, particularly those over 75. And most important of all, if it's possible to get the steroid dose down, do. If it's possible to stop steroid, do. Tuberculosis is not a major problem for patients who take JAK inhibitors, but nonetheless we should screen our patients for TB just as we do our anti-TNF patients, and we shouldn't give JAK inhibitors to patients with active TB. So if your patient screens and they have a positive quantiferon or chest radiograph, they should be treated for latent TB prior to starting a JAK inhibitor if that's the most appropriate treatment of choice otherwise. With respect to viral reactivation, again, make sure that the patients are vaccinated regularly for some of the routine viruses. That's very helpful. But the use of live or attenuated vaccines is not recommended for patients on JAK inhibitors, and that includes live attenuated zoster vaccine. There is a killed vaccine, Shingrix. It's only just available in our country. Maybe you have it too, but it is expensive. So if I'm going to use the live attenuated vaccine, again, you'd stop the JAK inhib for a couple of weeks, and ideally want to find out whether or not the patient has been exposed to zoster in the past, and you do that by checking antibodies. VTE, well, we've seen that VTE is a potential risk of JAK inhibitors, but it's a controversial issue. So think about the risks. Obesity, a past history of DVT or pulmonary embolus, patients who are going to undergo surgery or who are mobilized for a long time. And if they have a high set of risks for venous thrombotic event, then actually JAK inhibitors may not be the most appropriate treatment of choice. So think about risk and benefit, and just make sure a good medical history is taken. With respect to malignancy, again, this is a relatively rare problem, as we've seen, but we probably should screen our patients from time to time. An annual review clinic is very desirable, if possible, just to check patients for things like malignancy. And we must bear in mind that immunomodulatory treatments may increase the risk of lymphoma. However, that increased risk is small. So periodic skin examination is a good idea if appropriate. So in conclusion, what we've seen is that these approved JAK inhibitors are multi-cytokine inhibitors, now approved by the European regulatory authorities for the treatment of rheumatoid arthritis. In fact, there's another one that has just been approved, and that's filgotinib. The EULAR recommendations suggest a role for JAK inhibitors after failure of methotrexate or other conventional synthetic DMARDs, or after failure of one or more biologic DMARDs. So they have a place in most points in the treatment pathway. But we've seen that JAK inhibitors in particular may have an increased risk of herpes zoster, but also serious infections and respiratory tract infections, as well as high cholesterol. Generally speaking, these risks are very similar to those of biologic therapies, the exception being cholesterol and herpes zoster. And overall, the data suggests that malignancy and MACE events occur at a similar rate to background, which is very reassuring. Now, we do know that our patients with rheumatoid arthritis are at an increased risk of venous thrombotic events, and events have been observed in the trials, but whether or not there's any true causal relationship to JAK inhibition, I think, remains unclear, but nonetheless, we have a responsibility to think about baseline risk before starting the drugs. And finally, obviously, before you start any drug, as I'm sure you all do, think about the likelihood of benefit, think about the likelihood of risk, and make sure that the patient thinks that that's acceptable to them. I think that's the most important piece of advice. If I'm a patient, I want to be able to make my own mind up about whether I think the side effects of any drug are worth the benefits, and I think that's the way to have a trusting and good relationship with our patients. So thank you very, very much indeed for listening, and I hope you enjoy the rest of your session.
Thank you very much, Peter. In fact, we want to thank you very much and to give you a big applause.
Thank you, Catalin.
It was a pleasure, as always, and now the floor is open for questions from the audience. I can see Andra Balanescu. You most probably remember her from our last meeting. Of course I do. Yeah? So, Andra?
Can you hear me?
I can, Andra. It's lovely to hear your voice. Hello.
Okay. So, first of all, thank you very much for your presentation. It was a privilege, as always. So, I'm Andra Balanescu. Unfortunately, I'm not a young rheumatologist, but still a rheumatologist from Bucharest. I think that the issue of age is a very important one from the practical point of view. And you presented us in an extraordinary manner all the issue regarding this age problem. So, despite the data from the clinical research program of Tofacitinib, despite some data from the real world registries and so on, the reality is that today we do have a warning regarding the use of Tofacitinib in patients older than 65 years. Yes? So
that's right.
We cannot ignore that. Do you think that in the future similar warnings will be also generated for other JAK inhibitors, or is this a problem that is only related to Tofa?
Well, thanks, Andra. It's a great question, of course, and I think Tofa, in a way, has been slightly unfortunate. I suspect that this is true of all targeted therapies to some extent, that the infectious risk increases with age, and what has happened over the last 25 years? As you and I both know, the first targeted therapies were launched in the year 2000. Of course, all our younger audience will not remember that. But since that time, we've had more and more biologic agents that have come to the clinic. And then more recently, we've had the JAK inhibitors. And in fact, the latest one has just been approved. And what has happened over time is that the degree of scrutiny that the regulatory agencies put on the clinical trial programs and subsequent real-world data, I think, has got much, much more stringent. Now, of course, it's appropriate that the regulatory bodies should look at it in this way, but I also think it's slightly unfortunate for our friends in the pharma companies, because the degree of stringency has been, really very high indeed. So I'm not sure there'll be any difference if you dichotomize patient populations and look at other targeted therapies. I suspect we would see similar data. And to me, the most important take-home message is, yes, the regulators have given warnings about the use of these drugs in more elderly patients. And of course, depending on which country you live in and the local regulations, we may have to apply these, and it may restrict our prescribing in the elderly. But we must be very much aware that inadequately treated rheumatoid for a patient in their 70s who's otherwise very active, leading a full life, not only looking after their families and contributing there, but contributing to the community as a whole, that in my opinion, and this is just a personal opinion, that those patients should be able to make a decision as to whether they think the likely benefits of any particular drug are worth the risks. And I think this is a dialogue that increasingly we as rheumatologists should be having in a responsible way. Where there is data, we can fall back on the difference in risk. And there is a difference with tofacitinib, as we've seen. But in my view, again, it's not sufficient to completely ban use of the drug in all over 65-year-olds. And so I think the same issues apply, but we haven't seen the same data analysis for anti-TNFs or for tocilizumab or sarilumab or so on. So it's an area we're all going to have to be more and more aware of, I think, as we move forward.
Thank you very much, Peter. Any other question? May I ask you a question? We have a lot of restrictions imposed by regulators related to warnings derived from RCPs for different products. Do you think that those warnings are really have to be implemented in real world, or do you think that the doctor have its own judgment and can decide to prescribe or not to prescribe a drug to a patient based on any particular factors, risk factors, and so on?
Yes, thank you, Catalan. Again, I think it's a really good question, and for all the young trainees, I would say that as you mature in your experience of rheumatology, you need to learn not only the science of rheumatology and medicine, but also the art of rheumatology and medicine. And I think Catalan has asked an absolutely key question. We have a responsibility to take the warnings that regulators give very seriously. Of course we do. There's probably a medico-legal responsibility, if nothing else. But on the other hand, our overriding responsibility as responsible clinicians is to ensure the best possible quality of life of our patients. And in some cases, if there is, let's say, 5 in 100 risk of a serious event which is treatable, patients may well feel that that is acceptable versus the risk of undertreated disease, which may mean that they have a bed-bound and very miserable existence. And I think one of my criticisms of the regulators, I admire them because they do a good job, but I also feel we have to be constructively critical, because if we think of daily life, every one of you has crossed the road in Romania. I suspect that nearly all of you, if not all of you, drive a car, and some of you may have climbed some of the beautiful Romanian mountains. In other words, you have made a decision that the joy that you derive or the convenience you derive from those activities is worth the attendant risk. And every one of those activities carries a risk. And we can't live in a world where governments tell us that you can't climb a mountain, you can't get in a car, you can't cross the road because there's a risk. It's a question of putting it in a sensible context and then allowing the individual, who's a mature and adult individual, to make a choice. But we as responsible rheumatologists also have to guide them in that choice. And if there's a risk of death or worsening quality of life, we absolutely shouldn't be prescribing a drug. But otherwise, my view is that the art of good medicine is to choose a therapy with the minimum risk and the maximum benefit. But where there are several choices, where that risk-benefit equation is the same, actually the patient should be proactively involved in making those decisions.
Thank you very much. And maybe a second one. We are using already for some time two products, Tofa and Bari, and we have some experience with them. Different products are coming to the market. It's UPA and most probably Filgo in the near future. Some of them are claiming a selectivity on different classes of JAK inhibitors. Could you please comment on the clinical relevance of this selectivity?
Well, again, I think we as rheumatologists have to be a little bit circumspect about this. From a pharmacological point of view, the drugs are very different in a number of ways. One of the ways may be about their selectivity. So just for our more junior audience, I am sure you're aware that the Janus kinases are a family of 4 enzymes, and they work in pairs. There's one so-called homodimeric pairing, which is JAK2 with JAK2, but all the others are what we call heterodimeric pairings. So that would be, say, JAK1 with JAK2, or JAK1 with JAK3, or JAK1 with TYK2. So if you had a so-called selective JAK1 inhibitor, the question is to what extent would it inhibit those other pairings? It may, of course, not affect JAK2 directly, but not only might it affect those various pairings, but it could also have downstream effects on other cytokines that signal through different pathways. So I think we need to be circumspect about the selectivity stories. And in fact, close scrutiny shows that some of the drugs that have claimed to be very selective are not in fact as selective as they claim, depending on which biological assays you use. So here's the key issue for us as rheumatologists. In my view, we need to have a responsibility to scrutinize carefully the clinical trial data, just as we've all done together today, because then we can make up our mind about the clinical correlates in terms of safety and efficacy, depending on the particular selectivity profile of the drug. And don't forget, it's not just selectivity that matters, it's the half-life of the drug, it's also the way the drug's cleared. Is it cleared hepatically or renally or metabolically or a combination? And all these things make a difference, and they may determine the optimum prescribing choice. So yes, there is a difference in the selectivity of drugs, but overall the efficacy is broadly very similar, and whilst there may be some subtle differences in safety at a cohort level, we don't really know how to apply that at an individual patient level. So look at the clinical trial data, draw your own conclusions, don't be misled by hype, and then think beyond just the selectivity of the drug. And if you've got a patient with hepatic problems, then you might not want to prescribe a hepatically cleared drug. If you've got a patient with severe renal impairment, you probably wouldn't want to prescribe a drug that's cleared predominantly renally, and so on. So think about the bigger picture.
Thank you very much, Fida, for your answer. If no other questions, actually, Andra have one more.
A very short one. You mentioned before that you'd have some Asian patients, and I want to ask you, have you noticed any differences regarding the risk of herpes zoster in Asian patients born in UK and living in UK? So is this a problem related more to genetic background than to other factors?
It does seem to be a genetic background thing. In fact, I don't have sufficiently large samples of Asian patients to make my own conclusions from my practice, but there is data on this, and it does seem to be genetic. Some of our friends from Asia have mutations in the interferon genes, and we think that that's the cause for their increased susceptibility to Zoster, and a few of them are more likely to get the more serious expressions of Zoster. So yes, it's not, I think, geographical, it's genetic.
Okay, thank you again. If no other questions, it's my turn to thank you very much for your presentation, and just to say see you soon at the online conference on October 9.
I look forward to that very much. Thank you all very much, and enjoy the rest of your meeting. Thank you for the privilege of joining you.
Thank you very much, Peter. Have a nice day.
Take care now. Bye-bye, everyone.
You too.